Hello again. My name is Jeff Farbman from the Wallace Center at Winrock International. Welcome to another National Good Food Network webinar. In this webinar, Leveraging Healthcare Funding to Build Healthier Communities, we're blessed to have the leader of a coalition of organizations who shaped the law that she will speak about today. This requirement of nonprofit hospitals has great potential in affecting the health and well-being of many people, in part through healthy local food. Hold on to your hat. There's lots of detail here, but it's worth the journey. Our other panelists will share an inspiring example of leveraging this funding. So let me introduce you to the Wallace Center and the National Good Food Network. The Wallace Center, a business unit of Winrock International, is the host of the NGFN webinar series. The Wallace Center has been a leading organization in the movement for a more sustainable and equitable food system for over 25 years. Today, the center supports entrepreneurs and communities as they build a new 21st century food system that is healthier for people, the environment, and the economy. The center serves the growing community of civic, business, and philanthropic organizations involved in building a new good food system in the United States. In particular, we're focused on advancing regional, collaborative efforts around the country to move good food, healthy, green, fair, affordable food beyond the direct marketing realm into larger scale wholesale channels. The National Good Food Network, or NGFN, is an initiative of the Wallace Center. It is structured as a network of networks, ensuring efficient flow of information and innovation from boots-on-the-ground projects to the national level and back down to the grassroots level across the nation. The Wallace Center coordinates and supports the network. Our goals are to work with the growers to ensure that there is an abundant supply of good food to meet the high consumer demand for the product, to collect and disseminate the best models, stories, methods, and outcomes, and to ensure that policymakers are informed about the wonderful successes our network and partners have had so that we can continue to increase support for regional healthy food. You can learn more about the great work of the National Good Food Network and dig into our great resources to help your work at our website, ngfn.org. There we go. Marydale DeBoer, JD, is the founder and managing director of Fresh Advantage. Fresh Advantage works with hospitals to improve food and nutrition service operations, integrating attention to nutrition and food security status into patient care and community-based programs. The company tagline, "Food is primary care," emphasizes the connection between a diet of fresh, nutritious, and affordable food and health. She is a lecturer at Yale School of Medicine, Department of Psychiatry, where she works with medical students, residents, and fellows regarding the role that nutrition and food insecurity have in understanding, preventing, and treating a host of diseases, both physical and mental. Fresh Advantage also works with foundations and community-based organizations on matters related to food system reform and addressing food insecurity. In 2013 to 2014, Marydale led a coalition of organizations that successfully advocated for the inclusion of language in the 2014 IRS final rule requiring tax-exempt hospitals to implement a community health needs assessment. This is a process that makes clear that community health needs go beyond unmet clinical needs and includes access to adequate nutrition and social conditions that affect community health. She lectures frequently on the subject of community benefit obligations of tax-exempt hospitals, today included. And Martha Page is the executive director of HARTFORD Food System Incorporated, a nonprofit organization that has been devoted to food security programs, including urban agriculture, policy, and advocacy since 1978. Before coming to this role in January 2010, Martha was an environmental health director for the City of Hartford Department of Health and Human Services. Prior to completing a master's degree in public health in 2009, Martha spent more than 25 years in the health insurance industry in a number of executive positions. In addition to the MPH degree, she has a CPH designation, an MBA, and a graduate certificate in nonprofit management. A Hartford resident, Martha volunteers as a member of the Hartford 2000 Board of Directors and in cycling advocacy. Marydale, let me turn the mic over to you. Thank you.
Thank you, Jeff. I'm delighted to be here, and I'm especially glad to see that you have such a great turnout today from all across the country. So let me start by saying that I do have a series of slides. Some of them have quite a bit of information on them. What I'm going to try to do is simply to hit some highlights and rely upon you to review the slides at a later date for the detail, and you'll have them to go back to in order to review what we covered today and any notes that you might be taking. First of all, I want to say that we have to understand this whole field of community benefit as one that has evolved over at least 3 to 4 decades. So I'm going to cover the history of that requirement of tax-exempt hospitals. Then I'll focus on the Affordable Care Act and the provisions in that legislation that made some very significant changes to what the community benefit obligation is really all about. Then I will talk about the rulemaking process that ensued following passage of the ACA in 2010 in order to provide additional detail and direction to those who need to comply with the rules, that being tax exempt or what is often referred to as charitable hospitals. I will focus on provisions of that final rule that address what is deemed to be a significant community health need, and that is the area in which others and I work together to have language included that goes beyond needs being limited to clinical services, which is to say that those needs that are examined by hospitals in the course of this community health needs assessment process can include access to adequate nutrition, disease prevention, social conditions that impact community health. As a starting point, I'd like to emphasize that the Affordable Care Act was really designed based upon what is known in the healthcare sector, and many of you may be familiar with it, as the triple aim that we seek with this new policy, set of policies codified in the Affordable Care Act to provide better care, better health at lower costs. It's important to keep that in mind because embedded within the statute is the community benefit responsibility of tax-exempt hospitals. That requirement is not a freestanding set of policies, it's integral, and the changes made to that rule are integral to the achievement of the objectives of the legislation of the ACA. So let me briefly state that the evolution of the requirements for the charitable hospital exemption parallels expansion of insurance coverage in this country. So the policy always underlying this notion of tax exemption is derived by the notion that hospitals exist to promote the general welfare of the public. So in 56, tax exemption could be demonstrated by a hospital seeking that status to just simply state that charity care was provided, quote, to the extent possible. In 1965, with the advent of Medicare and Medicaid, the IRS expanded their definition of what constitutes community benefit, expanding it to include public health, health promotion activities, and activities beyond charity care. Then, in 2008, and this was simply not a statutory development, but an IRS initiative, the IRS revised what is known as the Form 990 Schedule H, which is the reporting tool that hospitals are required to submit annually to demonstrate how they comply with the rule and what activities they are pursuing. I mention this now because this came about not simply as a result of the expansion of the public health insurance programs, but because between 1965 and 2008, there was a lot of activity in Congress that was questioning how well hospitals were really doing with meeting this requirement for their tax exemption. It is a valuable exemption. Many benefits derive from it. Sarah Rosenbaum and others at George Washington recently published an article in Health Affairs that estimates the value of the exemption at about $26.8 billion a year. The specifics of that include such things as being exempt from federal, state, and local taxes, although in some states, and I won't get too technical on this, there are some ways in which a tax can be levied. It also includes access to the tax-exempt bond market, which is extremely valuable, and that's a way of financing construction and other things for hospitals. In addition, it includes, and very often people don't think of this, the value of the ability of individuals to donate to the hospital and thereby reduce their own individual income tax obligation. So to be sure, it's valuable, and there were a series of hearings, a series of activities, particularly led in Senate Finance, really demanding more transparency and accountability on the part of hospitals. Thus, the Schedule H was developed to promote exactly that transparency. Then we have 2010, the Patient Protection and Affordable Care Act. Insurance coverage expands greatly beyond Medicare and Medicaid, and we have here the opportunity to thus sharpen the provisions with respect to what is really the kind of commitment, the kind of dedication, and the kind of investment hospitals should make in their communities in exchange for what is a profound privilege of tax exemption. In the ACA, the statute itself, there was a triennial regulatory framework instituted, which is to say that hospitals were required to conduct community health needs assessments. They were required, and we're going to go over this in detail in just a minute with the other slides, that they have to develop priority needs, that they then have to put together an implementation plan, and they have to evaluate and report annually on the progress they're making. So we have to think of this as a quality improvement model over a course of 3 years, repeated every 3 years, 1 3-year interval with these 3 steps involved, multiple steps involved, designed to inform the next triennial exercise, if you will. These are not intended to be standalone exercises. It's meant to create a trajectory of improving population health by those hospitals that enjoy the tax exemption. The final rule finally governs really the process and the content of what is now the second round of CHNA and implementation plans conducted by these hospitals. The ACA was enacted in 2010. The responsibility to go about conducting these CHNAs began in 2012. These cycles are important to remember when we get to where you all can engage in a process of relationship building and information exchange with hospitals in your communities. The final rule, which really puts the meat on the bones of the statute, if you will, was not issued until the end of 2014. So its content in the expanded language that was included by the IRS on social determinants, for which many of us really advocated and worked very hard, really applies to this second round of community health needs assessments. Specifically, those who filed their first round in 2012, and that's all keyed to their fiscal year and reporting requirements with the IRS, needed to file again in 2015. The rule came out in 2014, so they had not so much time to really look at that, although many of them did, and many of them do a very good job of incorporating real meaningful content into this work. But then the second set of filers, entities that file in 2013, are now working on their second CHNA, and clearly the content of the final rule really has a great impact on how they go about doing that. Then the third set, if you will, of tax-exempt hospitals in this country that filed in 2014 will begin working, or perhaps are already working on, their second CHNA, which will need to be filed towards the end of 2017. Again, the final rule is to inform those processes. So the first set that we have that were filed in 2012 and 2013 may not reflect all of the import of that final rule because we didn't have it until late last year. A few key points about the community health needs assessments process. Defining community is an exercise where the hospital has great flexibility. For example, specialty hospitals that provide only psychiatric care, or specialty hospitals perhaps that are nonprofit and do only rehabilitation services, may limit how they define community by the kinds of capacities they have to treat those specific conditions. But there is a standard approach to doing this, and those include geographical approaches. But it is very important to point out that both the statute, the ACA, and the rule specifically call out that it is not okay to exclude low-income, minority, or medically underserved populations in the definition of community, even if those populations do not constitute part of the hospital's existing patient population. So you cannot ignore what is at the doorstep of your hospital, even if those individuals are coming in for services. It's, in a sense, you see where the policy of anti-discrimination is coming through on this requirement. Here's where we, in assessing community health needs, where we come into the, excuse me, I need a drink of water. This is where we saw an opportunity, those that watched the policy developments at IRS pretty closely, and we're all very aware that most of the, quote, credit or reporting of community benefits that has gone on in this country is simply with respect to the provision of charity care, or the difference between the cost of care and what Medicaid reimburses. And that has to do, that is a very, very narrow world of clinical services that for which hospitals have taken credit. Now that we're in the era of the ACA and we have a set of policies in that statute that are directing us towards looking at prevention, looking at population health, these community benefit provisions are the tool for so doing on the part of nonprofit hospitals. So in the rulemaking, there were approximately close to 40 organizations that filed and said, essentially, now is the time and now is the opportunity, with the expansion of coverage and the need for charity care or uncompensated care going down, that this definition of health needs really needs to be expanded. There were a lot of different recommendations made by those who filed comments, and they are reviewable. They are posted on the IRS website. But importantly, the IRS really pulled out certain language as we who commented wrote it, and included the language, access a significant health need can be access to adequate nutrition, and this is direct quote, other behavioral, social, environmental factors that influence health in the community.
It's good without me. Awesome.
Are you able to hear me? I'm sorry, there's some background noise. I wanted to just quickly talk about the first steps in the process of the CHNA development. First, I also want to mention that community health needs assessments are not new creatures on the planet. Many states have required community health needs assessment. They have their own freestanding requirements, and for sure there will have to be some process of alignment of those going forward in the future now that we have a more robust federal requirement. Secondly, federally qualified health centers and public health departments have done these assessments, and in fact are key players in going forward in the development of CHNAs by tax-exempt hospitals. With respect to data collection, since we are talking to an audience here of organizations concerned with food system reform, food insecurity, and associated issues, this is a place where many of us see an opportunity to start building relationships with tax-exempt hospitals, which is to say, with respect to the data collection, if we look at a lot of the CHNAs that have been developed, we don't see the use of very many secondary data sets on issues such as food insecurity or conditions that would be drivers of health conditions that are illuminated when the hospitals are using data sets such as the county health rankings, et cetera, to identify what are the most prominent disease states here in our community that we should be thinking about prioritizing and addressing. So this is an area, to the extent that you are familiar with these secondary data sets, you are capable of helping conduct some primary research where food organizations can really get involved and help hospitals take a closer look, a more granular look at what could be creating conditions that we know are dominant. About 3 years ago, the American Hospital Association did a voluntary review of CHNAs by their member hospitals, and 70% of them listed obesity as a priority condition. Well, the next question is asked is what is driving that, and looking and getting some more data on why that is, so that a meaningful implementation plan can be developed. So these are some of the requirements with respect to community input. And this is where an opportunity exists with respect to food organizations interested in addressing food insecurity, and with reform of a food system can become very influential in the process. We have varying degrees of community engagement demonstrated in the first round of community health needs assessments that have been filed. So therefore, it's very important that we look at what the opportunity would be to scrutinize what's been done so far and become actively engaged and establish a rapport and communication with hospitals as they go about the second round of CHNAs. The IRS final rule, and this is an important procedural point, states that written comments on a hospital's first now, but preceding CHNA, meaning the CHNA done immediately prior to the one being developed in a given point in time, need to be considered and summarized in the CHNA that is being worked on at that time. So with respect to those that are developing CHNAs now who filed in 2013 and who must file again in 2016, any comments received on their first stab at this, post hoc the ACA, they need to provide a written comment on. So that means they need to read it and consider it. This is an opportunity for community-based food organizations to go to the hospital websites in their area where they all live together, look at what was done in the last round, and provide comments, make recommendations as to how they could help make it better and stronger depending on the role that food and food-related matters could impact the disease conditions identified in that community health needs assessment. So that's a first step in relationship building that you all could look at. There's no time limit on this submission, but the sooner the better. So if you're now, I think the most meaningful opportunity is for those of you that are in communities where the hospital's first filing was in 2013 to take a look now and to do your homework and see if there isn't an opportunity to make meaningful comment on what might be the drivers of illness in the community that may have been overlooked and perhaps not developed in depth. I want to emphasize also at this point that hospitals have a great amount of discretion in how they go about doing this. What is mandated is the 3-year cycle, is the requirement that they cannot ignore medically underserved or minorities, that they must work with public health departments or experts, and they have their choices among those, whether it's state, local, or health department. But they must, importantly, do a look back and provide information on what they have achieved from the prior CHNA in the next CHNA. Here, They also must, this is another opportunity for establishing rapport with hospitals. They must identify community resources that are available to address the issue. Again, here, if we look back over the first 3 years of filings, it's highly variable the extent to which hospitals have really done a thorough job of this. So if you go back and look at the materials posted by your hospitals, their CHNA and implementation plans, you can get an idea of whether they did all the homework they should have, and if they hadn't, you can, in a very friendly way, in the interest of promoting community health, offer to be helpful here with respect to resources you have at hand. You can also point out secondary data that would be useful in building their knowledge base as they move towards an implementation plan. So importantly, I think I skipped a slide here, sorry, let me go back. In this, I did skip a slide, excuse me. Here again, the hospitals have flexibility, and they have flexibility in terms of how they set the priority needs. They are bound to explain what methodology they used, and most are very concerned about using the lens of what we call feasibility or likelihood of impact. Many hospitals, since the ACA more refined provisions were enacted and the IRS rule promulgated, are very concerned that they don't have the reach needed or the capacity needed to address social determinants of health. They may feel they don't have the tools to address housing as a health issue or food as a condition and a causative dynamic in the creation of certain chronic diseases. Here again is where some education by organizations like yours can go a very long way. We are seeing more and more research being done on an epidemiological level by researchers at UCSF and at Harvard showing the linkage. These kinds of valuable resources can be offered up by food organizations in the form of local advocacy and partnership building. It's very important to build the case from the outset of the CHNA process for later interventions that you may be able to form in partnership with hospitals and maybe in some cases which to obtain funding. But without laying the predicate in the data collection, priority setting, etc. process, there is no leg to stand on in terms of saying, we could really help you, why don't we partner, why don't we go into this effort that will make a lot of sense, be highly impactful, because we have the capacity to help you do it with additional resources. I think that the hospital community and others are very concerned that there's a perception that all of a sudden there's this huge bolus of money available. That isn't the case. We are in a period of profound change when hospital operations themselves are going to change, the balance of how much, what kind of resources and how many resources, how much money they have for community benefit investors is going to change, and this is why we have to have the same kind of advocacy at the local level that we had at the federal level in the IRS rulemaking that led to this important language being included in the rule in the first place. Keep in mind that to promote transparency, all of the CHNA must be posted on the hospital website and the information disseminated widely. Hospitals are also obligated to file in their annual filings the website where their implementation plans are also filed. I'm finding that more and more hospitals are just automatically putting that implementation plan on the website as well. In addition, there's a simple letter request for this material that can be made to hospitals. Another important feature of this rule is that for the first time the boards of directors of hospitals are required to review and approve community health needs assessments and the implementation plans. That is a form of internal accountability created by the statute and the rule. it's also another way for some advocacy, because if these boards have local community members, a case can be made to them as well as to the kinds of things the community itself feels should be addressed and about which they are most concerned. With respect to implementation strategies, I think that the most important point here to state, and you can refer to your slides later, is that the hospitals are obliged to state what they will address, again, being driven in large part about what they feel is achievable and impactful and within their power to manage, and also what will not be addressed and why. And that's a very important point, because if they simply are throwing their hands up and saying, you know, social determinants is simply just beyond our reach, well, that may not be really an adequate excuse. It may be that they just haven't built the right relationships with community-based organizations and other experts in order to make it happen. And that kind of partnership building needs to happen over a period of time so they can understand that it isn't, and indeed that these social determinants are huge drivers of illness that they are bound to help alleviate. This slide, I think, states the obvious. We went over that. And I want to say a little bit more about the annual reporting to the IRS. In the final rule, the IRS stated that each hospital must provide a report of what they have actually done each year vis-a-vis the goals and objectives of their implementation plans. So here again is another device to promote transparency. We, the public, are the ones who, for the most part, I believe, will enforce this. The IRS doesn't really have the resources or capacity to enforce this with respect to every hospital in America. But the real shareholders are the public. So that by looking at the annual filings and seeing what was actually done, not just what was put forth in an implementation plan, is another way to acquaint ourselves with what's happening, the level of effort, and whether the effort is meaningful or not. So with that, I'll turn this over to my colleague Martha Page, who was able to have a very successful partnership with Hartford Hospital, where they pursued a multi-step process of relationship building and arrived at a very, very fine project to help the community.
Okay, good afternoon, everybody. Once again, this is Martha Page, and as Jeff said at the beginning, I am the Executive Director of Hartford Food System, which has been in the food policy, advocacy, and programming business for 37 years now. And I'm delighted to have the chance to talk about a project that we have been working with for the last it was in planning for about a year, and now we have had about a year of implementation, and I'll tell you a little bit about it. And it is a direct outgrowth of a community health needs assessment process that took place here in Hartford. A little bit about Hartford. Very briefly, Hartford is a small city, northeastern city. We have about 125,000 people, but we have a lot of challenges. It's a high poverty city, about 40% poverty rate, and about 50% of our children under the age of 5 live in poverty. Even though the recovery across the country has been very real, and it has certainly a little better economically here in Hartford now than it was a few years ago, we are still operating in the city with a 10% unemployment rate. And the median household income in the city is is less than $29,000 a year, and that contrasts with the surrounding county where the median household income is about $64,000 a year. So a big pocket of poverty in amidst a lot of affluence. With that comes high rates of health issues related to poverty, including lots of, high prevalence of diet-related diseases. And every few years, the University of Connecticut does an assessment of food security within the state. and that was their most recent assessment was completed in 2015, and among 169 Connecticut towns, Hartford has the highest rate of food, the highest risk of food insecurity in the state. So what am I going to do about that? I'm going to talk a little bit about how we got to work with Hartford Hospital. Some of this is a little bit of a reflection of what Mary Dale just very wonderfully went over. But partnering with the hospital here to actually implement a project related to health, food, and nutrition was done in the context of a commitment by Hartford Hospital to broaden their thinking about what community benefit means, and that is very much in connection with the evolution of this concept, as Mary Dale explained. The focus on prevention and community collaboration provided a very strong basis for our work with Hartford Hospital. And the community health needs assessment that was done, Hartford Hospital was in the early cohort. They completed their first community health needs assessment under the new set of requirements in 2012. They just completed their the new round just very recently. And the community health needs assessment here in Hartford was that generated the mobile market project that I'm going to talk about was completed in 2012, but it was done a little differently than you might see these around the country. The community health needs assessment was truly done at the community level. It was in 2012, it was a joint venture among the 3 Hartford hospitals and the City Health Department. And so this resulted in one assessment with a very strong focus on the social determinants of health as the language of how the assessment was presented. But even though there was one assessment, each hospital then implemented their own response plan. In the catchment area for Hartford Hospital, they looked at the data, and what they determined to focus on were the 4 areas that you see here. And what's particularly pertinent to the project that we implemented in partnership with them is the very high levels, very large prevalence of diet-related diseases that they were seeing among the population that they were serving, that they were primarily serving. Among the efforts that they supported through a community benefits grant program that they developed was the implementation of a way to get more fresh fruits and vegetables into the households of their patient population. Now, a little bit of background on this. We did not invent this topic in response to the community health needs assessment. Actually, Hartford Food System, working together with another local nonprofit organization, Hispanic Health Council, had been talking about trying to implement this capability for a number of years. And the decision to move forward, though, was, of course, dependent on support and funding. And we had tried to get funding through NIH, and we had made an effort to get some funding through USDA, and we had not been successful up to that point. But then the stars began to align, and the Hartford Hospital, the individuals involved in their community benefit activity, had their lead manager there had recently come from a community in Massachusetts that had implemented, with support from Harvard Pilgrim Healthcare Foundation, a mobile produce market. And in order to respond to the priority areas related to nutrition and diet that had been identified in the community health needs assessment, they became aware that we were interested in doing that as well, and a partnership was born. The Hartford Mobile Market was in planning for quite some time, and it was based on community-based participatory research that Hispanic Health Council did among their target population. And when they did research to determine what type of stressors were present in the environment of their target population. Food and the access to healthy food surfaced again and again. And because it was a largely Hispanic population, and primarily at the time that they were doing the research, a Puerto Rican population, a lot of examples came up about the produce vendors that would go through the streets in the islands and would sell their produce, and they thought that something like that would be really good. And so we, without going through all of the planning to actually get to the point where you can see the bus on the slide that you're looking at now, that research generated the planning and the necessary logistical things that we needed to do in order to get this operational, which we did in December of 2014. And you can see that there was a founding support by Hartford Hospital and, as I mentioned, Hartford Pilgrim Healthcare Foundation. And one of the things that was very important is that we get community input into what this capability should look like. And the number of bullet points that you see there on the slide, this is not free food. This is a mobile produce market. So, of course, for the population that we are hoping to attract to the capability, it needs to be affordable. There needs to be a variety. Our client population told us that they would like to see other things included, like nutrition education and other types of add-ons that would help them use produce most effectively, and that it be available at a number of different locations and at different times, and that it accept lots of different types of payment, including SNAP, WIC cash value vouchers. We take farmers market coupons, and cash, so a wide variety of ways to pay for things. The nutrition education piece of this is something that Hartford Hospital is very, very much tuned into and is working with us to ensure that that is a feature of the work that we're doing with the market. Here you see a map of Hartford. Hartford has a very small geographic footprint. It's only 17 square miles, and within that there are 17 named neighborhoods. Our target neighborhoods have about 42,000 people in them. They do not have any grocery stores in them, and they are among the lowest income neighborhoods in an overall low-income city. And we are now operating we have operated during the summer up to 12 different stops a week. It changes seasonally, and because we are going to be operating this throughout the whole year, sometimes we will be associated with Boys and Girls Club summer camps, sometimes with schools, sometimes with churches, and it will be a changing mix of stops throughout the year. Our intent was that the Hartford mobile market not replace anything, but rather complement other things that exist in the city, including a pretty strong complement of farmers markets. We have one supermarket in the city, but we have a number of smaller grocery stores, and we're not looking to compete with them or take any business away. We are intending for this to be an added attraction, an added way and a convenient way for people to get access to fruits and vegetables that might otherwise have a hard time doing it. We don't only sell local produce. One of the things that we determined is that our goal here is for people to overall eat more fruits and vegetables. And so our determination was that what we needed to have on the bus is what people wanted to eat. So in addition to as many locally produced fruits and vegetables as we can get, we also regularly offer bananas and mangoes and lemons and those types of things that our clients tell us that this is what they want, and this will help them eat more healthily at home. And so we have a secondary goal, in addition to increasing the consumption of fruits and vegetables, is to the extent possible, to create an additional market for local producers, including urban farmers, community gardeners that are certified to sell their produce, and a number of local farmers in and around Hartford County that view this as an additional way to get their produce to a population they're not currently serving, which doesn't require them to sit at a farmer's market, which is very appealing to a number of farmers. But next up in our partnership with Hartford Hospital, we are in the planning stages right now, working closely with the hospital and again with Hispanic Health Council to develop a fruit and vegetable prescription pilot in partnership with the reopening of a outpatient clinic that is going to occur later this fall. And so the goal will be a simple one, which is a prescription will be written and the bus will be outside. So there will be the possibility to get the prescription from a physician and to fill that prescription before you go home, get back on the bus or get into your car. So we can't do this without a lot of support. I already mentioned our founding funders, Hartford Hospital and Harvard Pilgrim, but we have successfully, since the implementation of the market, we have successfully attracted some USDA funding, some NBC Universal Foundation grant funding, and Bank of America, and we are also strongly supported by the City of Hartford in both practical, both philosophically and in practical ways, like providing a place for us to park a 39-foot transit bus so that, you know, we don't have to try to find street parking for it. So with that, I am going to turn it back over to Mary Dale, and she's going to wrap up with a couple of additional examples.
Thanks, Martha. That was great. We were so excited to have Martha available today to provide you such an important example of collaboration with respect to the community benefit process. A couple of things I'd like to call out about her presentation that I think is typical of what we will need to see happen in other cities and communities is that there is a mix of partners. I mean, you may have noticed on that slide, what's Bank of America doing in there? Well, cross-sectoral collaboration is really critical. Banks have Community Reinvestment Act responsibilities, give back to their communities, that is analogous to what hospitals need to do in the community benefit arena. So accreting these partners and combining resources and frankly expertise is really the way this work is going to get done in the future. I think Public Health Institute has done a lot of work on cross-sectoral collaboration and collective impact, and I would recommend you check out their website. I will say that I feel that the way in which, Martha and I have talked quite a bit about this, the 2012 Hartford Community Health Needs Assessment was conducted in a collaborative way with a view towards social determinants even before the final rule was promulgated late 2014, was pretty ahead of the curve. We don't see that everywhere. Now we have positive law to inform it in the nature of the IRS rule, and we can use that and use it in our advocacy for more work like Martha's in other communities. But I did want to point out that that was pretty forward-looking at the time. The other thing that I wanted to offer up today, and you have it for your reading, is some other examples for you to go to. A lot of people are looking at this and saying, what does this mean? And nobody's 100% sure, but a few people have done some very good work. And we are looking to the IRS for additional guidance and additional content to what is known as the Schedule H instruction. In July, let me say a few words about that. What does that mean? Is that more paper and more, information and website stuff from the IRS? Yes, it is. So we have the rule, but the instruction, the Schedule H instruction, is what hospitals rely on for assurance about what will count. that they can list that this is blessed by the IRS, this is a reasonable investment and consistent with the law. Well, we know we have already the language on nutrition in the rule itself, but those of us who work in this arena were very wisely Catholic Health Association and Community Catalyst saw the need to ask for more guidance with respect to housing and other social determinants, because the language of the rule is fairly broad except for the nutrition piece, access to adequate nutrition. So letters have gone in, and there's a lot of advocacy saying, please sharpen up this instruction so we know what we can rely on. Hospitals are classically risk averse in every way, so they're asking for this guidance. I think it's a smart thing. Two other examples that we wanted to call out for you is the, see, I think I have to go back to the former slide. I want to, Reading Hospital, here we go. In terms of hospitals realizing that they need to do some of their own primary research, if they have the resources to do that, at the beginning of the community health needs assessment process is exemplified by what Reading Hospital System did when it was doing a CHNA and saw this plethora of diet-sensitive disease screaming out at very high rates of incidence in the communities they serve. So what they did is said, what's the reason, what's driving this? So they commissioned the Food Trust to do a community food needs assessment, which is a very logical, like, sub-assessment that could fit in nicely with a broader CHNA. So this is something you can look at and see what one hospital did, see the methodology. It does have a heavy focus on retail access. Keep that in mind. That was what they wanted to focus on, but it's yet another concrete example that you, in addition to citing the Hartford Hospital, Hartford Food System work, could use in discussions as you build relationships with hospitals in your communities. Another example is, there we go. Again, the Food Trust was engaged in working with Lankenau Medical Center and the Department of Health of the City of Philadelphia. Here again, I think we all have as much work to do with our health departments as we do with our tax-exempt hospitals. They're the two anchors in the community that we have to have parallel rapport with and advocacy and education efforts. So this is a very nice report that talks about both what the hospital did with respect to its patient population, which is different from what they're obliged to do in the community at large for people who may or may not be patients, using prescription programs like the one that Martha's developing now in Hartford, and activities in farmers markets for the community at large. So this describes a fairly broad landscape of food and nutrition related work, some of which is patient specific, so it, quote, wouldn't count in a Schedule H reporting, but also a lot of it that is really for the community at large, which certainly would count for the purposes of IRS reporting. Before we close, and I know we'll move to questions and more comments by Jeff, I did want to call out a couple of other examples, and Jeff, we can follow up with folks providing them links, but ProMedica, which is a healthcare system in Ohio and southern Michigan, has launched a very important initiative dealing with hunger as a health issue. They're doing very significant work. There's a wonderful white paper by their CEO, Randy Ostra, on their website, and their initiative known as Come to the Table, and now more broadly the Root Cause Initiative, is another example of CEO leadership, which is extraordinary. And we need CEOs. We need to focus their attention on it, and they need to lead. Right now we have very good people in community benefit departments at hospitals, but in the end these are leadership calls and board of directors calls. So that piece is very critical. Thank you all for your time and listening, and I look forward to the questions.
Thank you, and yes, there are very many questions, so let's dig right in. First question is for you, Martha. What steps did Hartford mobile market take to avoid competition with local businesses? Was there any interaction with the grocery owners?
No, considering the retail environment in the city, that probably isn't necessary. I mean, we are going to places where the closest store might be a corner market that primarily sells, snack foods and lottery tickets. But we also, through other work that we do with Hartford Food System, we try to maintain a good relationship with the owners of the mid-sized markets. I don't know, they go by various names around the country. Here they are C-Towns and Bravos and Save-A-Lots. So we are not explicitly in competition with them, and we are only selling one item, which is produce. So we're probably not going to have a good stop that will be in their parking lot. But we don't have any particular rules of engagement that we've developed as a part of this. Haven't really needed it, I don't think.
Okay, good. All right. Marydale, there are several questions around trying to understand sort of the scope of people's local potential here. A question about, is there a dollar or percentage of income requirement on hospitals for community benefits? Does a hospital have to be of a particular size to have this requirement?
Okay, let me address that. No, a hospital doesn't have to be of a particular size. What they have to be is deemed to be tax exempt by the Internal Revenue Service, unless something's changed on that front. But importantly, there is no specific percentage requirement, a dollars or percentage of operating budget that the IRS mandates. There is, however, kind of a rule of thumb that is developed over time that 7.5% of a hospital's operating budget should be dedicated to community benefit investments. We have seen some other instructions come out that will dramatically, from the IRS, that will dramatically change what can be in the total amount. Up until January of this year, when an instruction was issued about third-party funding, hospitals were able to count funding for research and training that was not from their own resources. That now has been eliminated. So in the example that was given in a lot of the trade press, when it was proposed, it was later finalized, it was proposed in October of 2014 that you couldn't count other people's money, essentially, and then it was finalized in January. The Mayo Clinic had always stated that it dedicated 11% of its operating budget to community benefit. But when you do the math, post hoc, taking out third-party research and training, that number goes down to 1%. So that's a very significant difference, and it will apply mostly to large academic medical centers that have been counting those kind of grants in their math and on their Schedule H's. So we're going to see a lot of change here in the mix coming up, which is why I think it's best to try to make meaningful bridges with hospitals in a really positive way, because we really need to work together if we're going to deal with some of these very seemingly intractable and difficult problems, and hospitals are going to have to learn how to do resource reallocation.
Yeah, that is a great point. These folks need our help in a way to help them navigate, how to invest in make smart investments, which they're interested in doing. Marydale, you quoted a publication at $26 billion community health benefit.
That was an estimate. Yes, it was in Health Affairs approximately, I want to say 3 months ago, by Sarah Rosenbaum, who is a healthcare lawyer, very accomplished, very expert. She's written a lot about community benefit, but it was a publication in Health Affairs, and she and her team did a a really deep dive on what the value, the annual value of this exemption from among the approximately 60% of hospitals in this country are tax exempt. So that's not to say that that's a large pot of money sitting there for the asking, hardly. And it is, but it's meaningful when it gives you a sense of scale of the value of the exemption. And I think that's what Senator Grassley has been worried about for many, many years, and that's why he's done surveys and held congressional oversight hearings on this, because he's concerned about, first and foremost, the drain on the federal treasury, but also importantly, the, shall we say, ripple down effects in cities where nonprofit entities aren't supporting local communities through the tax base. They have to be doing other things to help with the quality of life in those communities.
Okay. Martha, you mentioned that you made a priority for having local produce in the mobile market. Can you give us a sense of how you make that argument that that not only healthy food is important, but also healthy local food is important?
Well, I don't. This Hartford has a strong heritage around farmers markets, and they've been in the city since, I don't know, since 1977, 78. I mean, a really, really long time. And so the idea of promoting local is not a hurdle that we needed to get over. What we need to get over, or what we need to address, and we need to address this at farmers markets and on the mobile market as well, is does local come at a premium, meaning that I can no longer afford it? And with our target population, we are seeing a very large usage of SNAP on the bus and WIC and senior farmers market coupons, which of course can only be used for local produce, and WIC cash value vouchers, other types of coupons that our stops are sponsoring us to make sure that this is affordable. But affordability becomes key. So if we put local tomatoes on the bus at a price that looks like it's too high, they're not going to sell. So our challenge, of course, is to work with local producers and make sure that they are getting what they feel is a fair price. And that's why that balancing, if we're buying something from farmers and they don't have to go staff a farmer's market, that is appealing, or we have found it to be so. So we haven't really had to sell the benefit of local, but we definitely do have to pay attention to the pricing structure. And we've been at this in the mobile market setting. We've been at this for a little less than a year now. So we're still feeling our way on the proper price points for things. And I suspect that is going to be ongoing for a while.
Now, I'd like to add to that, Jeff. I
Sure.
often in my dreams, I see a visionary CEO at a hospital saying, I can see how I could really make a super upstream investment by combining, for community benefit purposes, an investment in a food hub that would aggregate and make things all that much easier for farmers and consumers and help bring down that price point that Martha's juggling, and in a mobile food bus, or more than one, that would pick up its supply there and go to these poor neighborhoods where we can't get grocery stores to build. And in fact, some grocery stores that have just, gone in to, quote, a food desert and said, the answer is we'll go in and we'll put a new format grocery store in and blah, 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 and it still doesn't work because it's either not culturally appropriate, the scale is too large, a million different reasons. But if you could see how you could back out of very grassroots up to really looking at a series of upstream investments, the ultimate one being in something that would be real agricultural system infrastructure, which in community benefit world, we call that community building. Sometimes it counts on Schedule 8, sometimes it doesn't. I won't bore you with the technical lawyery stuff around that. We're trying to work with the IRS to get better definition. But this kind of thinking could be incredibly valuable for really, given the huge hospital sector in this country, to really turn around the grand experiment that started with Earl Butz and led us to the place where we are now, where we have so much diet-induced disease.
Well, there are several people on this webinar who could help direct funds properly in that way. The question I have for you, really for both of you, Marydale from the broad perspective and Martha from your actual implementation, is when you go to approach a hospital, who do you talk to? I mean, are there particular departments? How do you get sit down with the CEO to expand that hospital CEO's vision to match yours, Marydale?
Well, I think it's going to be different in every community. You may start with building a relationship with the public health department if you don't already have one, making people aware that you think of yourself, if you are a food producer, if you're a food advocacy organization, that you have a nexus to human health. And that's something you have to think through at your own table with your own board and with your own teams. Have we articulated that we believe we are an essential connection to human health, community health promotion, and the like? Then there are various entry points. And I think a critical one is making sure that we've built those relations with public health departments and also certainly with community benefit staff, which usually resides under the in community relations departments. They're shifting them around now because community benefit staff used to live in the marketing department. But if you go through the history of the legislation and the history of this rule, that's a no-no. Community benefit is not marketing to improve the hospital's cash flow. It's definitely not that. It's called out as not being that in the legislative and rulemaking history. But if you can find those staff people in community relations, that's a good place to start. If you know people on the board. But this is very much all in the nature of an educational effort. The best way to do is to offer to help first. Could there be a way that our expertise in nutrition education or the like, we could be helpful to you at a health fair you're holding, etc. It takes a long time to build trust and build rapport. But as I said at the beginning, and I'd like to say at the end again, is that if you want to work with your hospital, you really need to look through what was done in the first round, the first community health needs assessment and implementation plan that they did. Go to the website, ask for it, and get smart. And you don't start with the CEO. You have to build your case. You have to know what they care about. You have to know what they perceive to be the priority needs. And then you have to learn how to speak some of that language and to find a shared interest and a common purpose. I also think that in most cities, the city leadership is really important. They're elected officials. They represent the people who live in the city that has a smaller tax base than it otherwise would, but for the tax-exempt hospital. If it were paying taxes, then there would be more public revenue to deal with social determinants. I mean, the city from which I moved is one of the biggest examples around. A very small city with two enormous nonprofit entities, Yale University and Yale New Haven Hospital. It decimates the tax base there. So the leadership of the city really are people that we need to do work with there and saying, look, we've got to be able to articulate and make our case here. We have like the second worst numbers in New Haven of food insecurity, but we don't really have a way to deal with it out of our public coffers. We need us to cultivate a sense of responsibility on the part of these nonprofit entities who also make their home here.
In fact, the idea of an economic multiplier being more effective if you are buying local food is another good argument there.
Well, it's jobs. The more urban agriculture. Interestingly, in Stamford, Connecticut, they did a very, very interesting community benefit project with a local group there, and they invested in a housing combine and an urban farm. The urban farm has workers and supports local access, like Hartford Food Systems, Martha's group, also does urban farming. Now that's a really smart move from a community benefit point of view. That's Stamford, S-T-A-M-F-O-R-D. So these are possible, but it does take time to become acquainted, educate the hospital as to your bona fides, your abilities, your capacities. And over time, we are seeing more and more of these things happen.
And I'll point out that Martha's organization has been around since the late 70s, and so there's some familiarity and knowledge, and Martha has such a strong health background that I could imagine that a hospital would feel a level of comfort there.
Yeah, from the late 70s and in a community that's 17 square miles. So, they know us. So, and I think that the relationships is a really important thing. And I want to just reemphasize just one point, is that working through the local health department, if the local health department has a good relationship with the hospitals, which they often do out of necessity, then I think that building a relationship with the local health department is a really good entry point to those discussions.
I agree.
All right, there are several more excellent questions, but we are out of time, so I want to give a hearty thank you to both Marydale and Martha. This is eye-opening, and I like where we ended on a very instructional and inspirational note. There is truly great potential in the community health needs assessment, and Martha's work is a wonderful example. I feel inspired. I hope you are too, and you feel empowered to leverage this for your own communities, realizing that relationship building takes time. So patience is a virtue. This webinar is being recorded. It will be archived on our site at ngfn.org/webinars, along with the other webinars in this series. We have over 50 other webinars. Feel free to send others who think would have liked to have heard this presentation, and take some professional development time, dig through our excellent archives. They are organized by topic in the left-hand side navigation area, and we'll have this one up within a few business days. We offer our NGFN webinars on the third Thursday of each month at 3:30 p.m. Eastern Time. Sign-up links are always posted on ngfn.org/webinars, but make sure you get on our mailing list so you hear about our webinars first to reserve your virtual seat. October's webinar is not yet finalized, but in November, we're pleased to host the researchers at Michigan State University to present the findings of the latest National Food Hub Survey. If you want to know the state of the art of food hubs in the U.S., you should not miss this webinar. I mentioned at the top of the webinar about our conference, but in case you joined us late, please save the date, March 30th through April 1st, to attend our conference that has a laser-like focus on food hubs. You can find the NGFN on YouTube, on Twitter, and on our website, ngfn.org. The Wallace Center is also on Facebook, so come like us. You can search for Wallace Center at Winrock International. And again, if you haven't already, sign up for our email updates. There's a link on the ngfn.org homepage, or just let us know in this post-webinar survey. We will sign you up. Contact us at any time. Our email address is down there, contact@ngfn.org. The NGFN would like to thank you for your time today. And once again, let me encourage you to fill out the survey that opens in your web browser in just a moment. We offer these webinars free to you, but of course we need to let our funders know about their impact. So thank you, and this concludes the webinar.